Hi everyone, good afternoon, and thank you for joining us. Before we begin the session, I would like to introduce a few admin details for you to take note of. If you have any questions during the session, please feel free to type that using the Q&A button, and we will take your questions during the Q&A segment. So lastly, please do not go off immediately at the end of the session, as we need your help to fill up a simple feedback survey on today's session. So thank you once again for joining us today. My name is Sinman, and I'm from the Smart Nation and Digital Government Office. Smart Nation Together is an online program that's developed by the Smart Nation and Digital Government Office as an online platform to share on tech-related topics and skills. So here we also encourage the community to expand the mindsets to consider opportunities in the digital economy. So in today's session, we present to you the use of AI in healthcare, particularly in Singapore. Without further ado, please let me welcome Ricky, Deputy Director in Integrated Health Information Systems, IHiS, Data Analytics and AI Department, to share with us today. So over to you, Ricky.
Thank you very much, Sinman, for the introduction. Good afternoon, everybody. Happy to have so many of you join us here for the lunchtime session. Happy to see a lot of interest from all of you. So hopefully what I share will be something that will satisfy your appetite here in exchange of the food that you forego for a while. I will start later with a bit of introduction of myself and getting to know you a bit better after that before I go into the material proper. Give me a while the screen appears. So, this is me. Face match, right? I just realized that actually the clothes also happen to match. That's not by design, but okay, that just verifies that this is me. I'm Ricky. I'm the Deputy Director for IHiS Data Analytics and AI Department, like what Sinman introduced for a while. So I've been leading the various IHiS data science initiatives. And in particular, data science, sometimes people think data science is very scientific, very research. I want to emphasize that a lot of our work and my work, the emphasis is not purely just for science, but in particular in applying them, implementing them. And for my work and for the topic of discussion today, specifically for public healthcare, I'm very passionate about analytics in general. So it's not just data science. Data science is just part of a wider spectrum of using data for the benefit of humankind. I'm passionate for analytics as a whole. So I also do that as part of outside my life, trying to sometimes introduce data to even my children, how to use data for their choosing how to go to theme parks. So happy to do so as part of my work, and happy to share more to the rest of the people here. So that's a little bit about myself. And now maybe I can get to know a little bit more about yourself before we start the talk. So you should be able to see now on screen this QR code for Mentimeter. Some of you may be familiar with this. Please scan it. Or if you don't have a QR code handy, you can go to menti.com as the URL at the top and key in the code, the 8-digit code over there. I'll wait for a while for everybody to get ready so that you can answer a couple of questions later to share more about yourself. So I know roughly who are the people here, and maybe just a little bit how much I spend time on certain section of my talk accordingly. I'll wait for maybe another 15 seconds. So for those who haven't taken out their phone, are you waiting for 10 more seconds counting down before I move on to the next slide? Oh, by the way, I'll be having a few questions here and then a few more further down the road after my presentation reach about the halfway mark. So once you get in there, you may not want to log out, so you can help me get some more feedback afterwards. But without further ado, let's now go ahead first with the first introduction question. Tell me more about yourself, your age group. Wow, the responses come very quickly. Must be a young group, very fast responses. Oh, I stand corrected. In fact, the age group that seems to be the biggest now is above 40 and is responding very quickly. Okay. Yeah, let me dwell for about maybe 15 to 30 seconds over here. So I encourage everybody to respond. I see that responses now is almost 70, 80 people. I think there are about 150 participants. So for the rest, what are you waiting for? Okay. the numbers slowing down already, so maybe last 10 seconds before I move on. But okay, pleasantly surprised to see a lot of above 40s in this group also. None below 20, interesting. Everybody's still in school, I guess. Okay, thank you very much for all these responses. I think this is the simpler question. The next one will be a bit wider. I'd like to know which industry are you from? And I wonder if most of the people here are already in healthcare or from other sectors. Audit, wow, interesting. Healthcare, as I expect. Wow, a lot of people in healthcare. Okay. Mainly healthcare, health tech. I see a few in IT, banking. Oh, I'm glad that even though there are those who are retired who come in here, because I want a wide audience to appreciate the use of AI. It's not just for the working people to learn in terms of how to make use of AI, but also how to adopt AI, which will be the broader population. Okay, wow. So by and large, almost every, I guess more than 50% are actually from healthcare. Okay, so maybe I'll move on to the next question in about 10 seconds. Healthcare supply chain, interesting. Social media, oh, wow, that's a very powerful industry. You can influence everybody and every sector, including healthcare. Okay, so thank you for all the active responses. And for my last question, before I start the talk proper, I'd like to know your involvement in AI or data science, if any, whether you are already part of it or actively part of it or actively looking to be part of it. Okay, so majority are quite unfamiliar with AI. Happy to have most of you here to get a bit more of a glimpse to demystify what AI is and what AI in healthcare is. The middle bar is the one ticking slowly, looks like. 3 people in AI and data science. So okay. You may find this talk then later maybe a bit of a recap of what you've been doing, and I will try to make sure we represent our field AI and data science well to the rest of the audience here who I think would be more interested to see in the sense of how to apply this AI and machine learning in that sense. Okay. All right, thank you very much for the various feedback. So I will then move on then into my talk proper. Yeah, today I will be covering mainly the use of AI in healthcare. So I wanted to make sure that everybody have a good sensing on healthcare. But from what I see in the audience, actually majority are already in healthcare. So I may go a little bit faster on this, and if there's any particular area of interest regarding healthcare, maybe I can address that separately at the end during Q&A. There'll be a short Q&A session that we'll have time for. So a quick overview to set the background. Healthcare is actually one of the largest and fastest growing industry in the world at the moment. May not be obvious to many people because maybe what you hear more from advertisement in media, etc., more the consumer-based retail or the high-tech sector. But actually, if we measure it in terms of the number of resources spent and the size of economy that's spent on healthcare, is big and growing. In fact, healthcare consumes more than 10% of gross domestic product in developed nations. So, I mean, if you follow USA, it's a well-known problem there where the cost of healthcare is blowing out of proportion. I think about 16% of the GDP is the cost of the healthcare at the moment. And in most other developed countries like Europe, UK, it ranges about 10%, 11%. For less developed country, the numbers are smaller, single digit, but again, that goes hand in hand with the quality of service, quality of healthcare that they receive. Excuse me. Singapore is actually doing well. Singapore have been keeping the healthcare costs under control. I think we're in a good range of single digit percentage of GDP. However, we need to be mindful that trend-wise, the worldwide trend, especially in the developed nation, that also applies to Singapore. Growing population, aging population, those will continue to exert pressure on the health industry, and that also means there'll be growing demand and growing size of the industry. So in Singapore public healthcare context, the population trend, the growing number is one thing, but the aging population as reflected here, 15% of the population by 2019 is already above 65 years old, and in 2019, 83.6 years old life expectancy. This leads to increase of demand in terms of healthcare being needed, because it's not just the number of people. The longer the year of life is, the more time that they may need to go to seek health services. So at the right top box, you can see currently we're serving more than 12 million admission, visits, etc. every year, and this is growing, and this is just the public sector. Bottom left, you can see that in developed countries, typically the causes of death are those chronic illnesses, diabetes, respiratory diseases, etc. So this is going to continue and exacerbate the demands and also change the demand of services, because these are typically diseases which are complex. Diabetes alone will possibly lead to a need for service for cardiovascular related diseases, renal related diseases, food conditions, etc. So all this changes the way how we need to plan and serve public health care. It is multidisciplinary. It requires many people. We need to support through a lot of health professionals. Here you can see a wide range of people, more than 70,000 people actually in Singapore now. Make sure we are all well taken care of. So salute to all of them. And these are just the people who are the visible face in the clinics, the doctors, the nurses. We should not forget the people who are supporting, enabling these people to deliver the care. The hospital administrators, the operation people on the ground. So it's actually a huge workforce and a huge resources that needs to be dedicated to support healthcare here. Which brings us to IHiS. So IHiS is, I'll go a bit more to describe what we are, but our mission is to help support all this by digitizing, connecting, and analyzing the Singapore health ecosystem. So for those who are not familiar with IHiS, we are the health tech agency for Ministry of Health in Singapore. So we are 100% owned by MOH Holdings, who's in turn 100% owned by Ministry of Health. And we are the IT service provider for the healthcare clusters in Singapore public sector. So a quick recap, Singapore public health system is organized into 3 clusters who broadly cover different geographical area in Singapore: SingHealth, National Healthcare Group, and IHiS. And under them, they provide various services. The most visible are the hospitals like Singapore General Hospitals under SingHealth, but they also cover other areas like the specialized clinic, like the cancer clinic, national eye centers, etc., and also the polyclinics, etc. And besides those clusters under MOH, also there are agencies who specialize in certain functions to support the running of public health. IHiS supporting the tech area, and we have the AIC who support integration of care, procurement under ALPS, etc. So it's a huge ecosystem to make sure that all the citizens are served well. And our ultimate aim is to improve population's health and improve health administration. In the case of IHiS, is via technology, by integrating suitable technology, intelligent, resilient, cost-effective. This is a snapshot of how we do that. We design and implement a wide range of IT solutions, nationwide, cross-cluster, within the healthcare cluster. And you can see from here the various functions serve health analytics, mobile apps. And you can see as we go into further detail, delivery of functions in different areas may require specialized systems. You have ambulatory care delivery, which is different from acute care. For different functions, you also all need a respective system. Medical imaging needs a system, monitoring of vital signs needs a system, laboratory needs a system. And taking outside the clinical area also, you need systems also to manage the running of the operations. So health financing may be something that is not directly associated to providing clinical care, but actually is very important, especially in the context I mentioned just now about keeping the cost of healthcare. And also managing the movement of people. You have a bed management system, meal ordering system, RFID tracking of various assets. All in all, I hope this gives you a bit of a sensing that healthcare, beneath the iceberg, there's quite a lot of things happening, which is why IHiS is the largest health tech company in Singapore. Size-wise, the technology projects we manage every year is amounting to about $700 million upwards. And to deliver this, we are at the moment about 2,400 people and growing rapidly. The number of systems we manage to cover all the functions I mentioned just now is about 800 plus. That's a big number. It's growing, but not rapidly. This is one of the areas that we do not want it to grow rapidly. In fact, one of the strategies is to try to see how we can keep this in check so that we can manage the costs, but not compromising on delivering function to the public health. But in short, basically, all public health institutions in Singapore run on IHiS powered tech, and that's why we are huge and growing. And by the way, we will continue to need help. So if any of you are interested to support us, find us maybe outside this talk. The breadth of what we do here means that we need to have a proper way to strategize to manage how we deliver, which is why IHiS is also looking after the strategy of how to deliver the technology across various segments. But I'm showing you this slide not so much to go into the strategy, but to illustrate a bit the breadth of coverage and possible use cases in healthcare. You can see from the left where it starts actually from population of prevention care. So healthcare, we're not looking only starting in health institution, but how we can help educate the population to prevent conditions to be deteriorating. The next progression is of course the primary care, your typical GPs and polyclinics and possibly dentists, etc., where hopefully we can take care of most of the cases before we need to progress into acute care in the hospitals and specialists. And beyond hospital, after the discharge, there's a need to provide intermediate and long-term care, and eventually when the people integrate back into the community, how to continue to provide social support and community care. So this is actually a whole breadth of spectrum, and all these areas are areas where technology and analytics can contribute to help for healthcare. This also illustrates how rich healthcare in terms of function and in terms of the data. The data is basically as rich as the systems. As you can see, there are 800 over systems. There are just so many data that you can capture. At the tip of the iceberg, what people often associate when we talk about healthcare, like what I mentioned, will be clinical related, the diagnosis by the doctors, the patient history that is recorded in the electronic medical records. But beyond that, every specialized function may have their own capture of information, the labs, the pharmacy. And as we progress in healthcare technology, there are new frontiers being covered. At one extreme is the deep understanding being breached by our scientists, where they go into genomics data, uncovering so many personalized data of every individual at the DNA level, all data which can be captured and harnessed for use. At the other spectrum, there are those at the consumer end, where the availability of sensors and wearables means that more and more even data is available outside the visibility of the institution, but all can contribute to improvement of health. And as I mentioned, not to forget at the bottom of the foundation of supporting of this clinical and more medical related one, actually there's a lot of operational data, administrative data like appointments and visits and how institutions run, and also financial related data, which may relate to billings, costs, claims submitted, reimbursements, etc. It's very rich. All of them can operate independently, all of them can be integrated together, and that's where the opportunities lies in healthcare, and also actually the challenges, which I will touch a little bit later. With this as the background, you can imagine that there's a lot of possible application of AI, and I'd like to take the opportunity of the next maybe 15 minutes to share 6 cases for which IHiS has been involved in terms of delivering AI products in Singapore healthcare landscape. You would have seen a lot of these various overseas also data with all this value, the amount of data available in healthcare. a lot of possibility of delivering various deep learning algorithms for diagnosis this, diagnosis that. But by now you should know that there are other areas besides clinical that it can be used for. I will start with the first one, which is our first predictive model we've done, which is a nationwide predictive model for admission prevention. A little more background from a use perspective for this. Back in 2017, 2016, there was an initiative for this program called Hospital to Home. Basically, the premise is this. As I shared earlier, there's increasing demand for healthcare resources, including hospital beds. So there's limited number of hospital beds available. There are a lot of people who are competing for this. So the thought is, how can we make use of this more effectively? Is there any way for us to differentiate who may require this bed more critically than other people? And for those who may require this not as critically, is there any other way to provide care for them such that we can free up more hospital beds for those who need it more? Hence the Hospital to Home program, where the premise is for those who we can identify that care can be provided at home without compromising the quality of care, then we can support them to continue the treatment at home and making the hospital bed available for others. So that's the premise of this nationwide initiative. And for this program, IHiS works together with the various hospitals here, CGH, KTPH, NTF, etc., and with the support of the ministry, to develop a way exactly to identify these people, identify high-risk patients who we can support them in their journey to integrate back to their homes. Now, it may not be as simple as just saying, okay, let's identify and go. The operational constraint here is that let's think about how, if we want to do so. So first, once patients are admitted, then the hospitals may need to have a way to assess and enable these people. So they need to assess the condition before they discharge. Oh, this is suitable, so let us equip you because we don't want to let you be hanging and then the care quality decrease. But imagine if you need to do this with so many people, it will be such a logistical hit. It will require so many people, so many of the nurses, etc., who need to be channeled to this assessment. Hence the idea of using a machine learning predictive model to lighten this load. If we can identify the high-risk patient that needs to be targeted by these people, this is how we can reduce the workload of the nurses who need to support the implementation of this program. So we're happy to see that with the use of this model, up to 90% of the nurses' workload have been reduced. And since April 2017, more than 19,000 patients have been enrolled as part of this program and helping us manage the capacity and usage of the hospital bed. So this is an example of one of the earlier use of AI in public health in Singapore, from a population health perspective using a historical patient medical data. I'd like to share also other use in other settings. In this example would be narrow, not nationwide, but used within an institution. Application of C3 application. C3 stands for Command, Control, and Communication. It's not a term that originates from healthcare. In fact, this is a concept that comes from the military, where you can imagine, let's say if you watch those war movie or even those sci-fi movie, you have a central place where the general sits there and have an awareness of all the situation on the ground and then issues order, okay, you go this side, tackle this problem, that side. That's what you see at the top left, the snippet there. Something like this you may have seen visually in some movies, all the screens appearing. This is something that is being replicated in healthcare, pioneered by Tan Tock Seng Hospital and the National Center for Infectious Disease. So what happens is that you could imagine now the operation on the ground in a hospital is not so straightforward. Having to coordinate all the different flow, all the different functions, different part of the hospital, it will be useful for them to be able to have a good visibility of what's happening where, what's going to happen next, and make an evidence-based decision, something that's informed by data. So that's exactly what this C3 envisioned to deliver. With support of IHiS, TTSH, and NCID created this first worldwide application of C3 in a healthcare setting. And it leverages all the data that get captured on the ground and analytics to make life easier. So they make use of video analytics to help count people on the ground. They track the various choke points and anticipate if there's any area that may require more resources, which then can be monitored by the operation people here and inform their follow-up action. The data that come in are fed into simulation engine to try to anticipate when there will be a surge in loads, etc. They also even monitor social media to get any clues if there's any anticipated surge coming in. So all in all, is a concept that has been working well, and in fact, it got a chance to prove itself when there's a spike in demand during the COVID situation. So we are positive that this will be a case that may be useful to apply to more and more hospitals, and also an area where we can build in more AI to make it more manageable in, as mentioned, evidence-based way, data-driven way. So the data here is different from what is used in the earlier example of hospital to home. The data here is mainly situational awareness data of life situation in the hospital itself. The next example that I want to cite actually uses yet another different kind of data, in this case, image data. So what you see at the left side here is an image of the eye, the retina, taken with a special camera. So these are the kind of data that they use for this deep learning system for diabetic retinopathy and eye disease detection. So the Singapore National Eye Center, in collaboration with the Singapore Eye Research Institute and NUS, have collected a trove of eye image data that they use to train this system to be able to identify diabetic retinopathy, glaucoma, and age-related macular degeneration. Now, why do we do that? So this goes to the chronic diseases I mentioned earlier, like diabetes, for example. Diabetes can lead to many conditions that can deteriorate. You will want to catch them early so that you can prevent them. So it's advisable to have screening for various conditions, including eye. So in Singapore, there's eye screening being put in place as part of the process for various diabetic patients rolled out by the various polyclinic. And you can imagine the scale that it needs to roll out, juxtaposed with the fact that I mentioned earlier, there's a crunch in manpower, especially specialist manpower, to be able to identify this from evaluating eye images. That's a specialist knowledge that, of course, we want to train more specialists, but there's a bandwidth, a limitation in scale. So what happens here is IHiS helps in terms of digitization, where we're not evaluating the people on site. These images are captured. It can be done centrally by a pool of trained specialists who can then support worldwide, nationwide, all the screening initiative. But we take it one step further. How can this workload for the people in this centralized location be improved even further? So this is where this predictive model comes in, where this model will allow identification at a quite good rate, sensitivity of 90% of specificity, reasonable specificity. And hence, it can really help turn around more of the cases, especially cases where it's clear-cut. It can immediately be result be churned out. We have cases which are more complicated, is where it will then be referred to specialists to take a second look to confirm what's the diagnosis over here. And with this, is the entire system is able to bring down the time taken to grade whether a particular condition exists or not from days to minutes. So this is something that is currently being rolled out, and we hope to be able to really deliver the benefit of being able to deliver the assessment faster to all the patients pretty soon, actually. I think you may have heard of this in the news a few times, because this actually has been running on for a few years. Another example that is related to image is for wound assessment. This is a data product which is developed by Chronic Care in collaboration with IHiS for piloting in several institutions here, where the premise is taking an image of a wound and being able to assess it with the help of AI will allow faster assessment and triaging of the people. So the AI will allow, based on the image, to identify the depth of the wound and take into consideration the tissue condition around it, being able to identify how likely this is going to progress worse. So imagine if one day this is something that a patient can take a picture and then send it over without needing to go visit in person. That's where we're going at. That's how we want to try to minimize the crunch with some nurses having to evaluate this wound condition for every individual. Similarly, this will allow perhaps improve comfort in the sense that if we can just take a picture without, maybe in some condition you need to touch and then try to tweak around the wound. If we can do this just by taking picture and assess it, that will also improve not in terms of the turnaround, but also the comfort for patient. So this is something that has been piloted, and this is an example of how IHiS actually brings together the wide community of stakeholders within the healthcare sector. IHiS doesn't do everything alone. We develop some of the model. We incubate and support some of third-party commercial institutions. In the earlier example, we collaborated with the academia who have developed good model that we can then take to deploy. So all of these are how we see AI can continue to influence and improve public healthcare with IHiS' involvement. The next example is, again, relying on image, but taking it one step further, where we actually combine the data, not just image, but image and EMR data, the patient's medical record. So this model, Community-Acquired Pneumonia and COVID-19 Predictive Engine, what we call CAPE, is something which in a way got boosted with a jump start due to COVID, due to the urgency to see how we can speed up diagnosis and identification of patients who need urgent care. So this is something developed and implemented by CGH and IHiS at the start of the COVID wave. With this model, the intent is to be able to identify earlier pneumonia patients who may need differentiated treatment due to the risk that associated to them, be it the risk of them dying or the risk of them having a condition that advance rapidly, meaning that they need to be admitted to ICU. But at the same time, those who may be possible to be discharged in 2 days or less, and hence we can manage accordingly. So this is something that is still being piloted and is pending certification as an AI medical product. And we hope that the adoption of more and more such model actually also brings more comfort on how to use this for more different conditions as well. So these 5 are the one which I would say more easily relatable in some cases. I'll give another example of a use of AI in an area which may not be as obvious to people outside healthcare, which is related to the data itself. In this sense, data generation, synthetic clinical data generation. So in earlier examples, it's making use of data to deliver some information, but here we're trying to create additional data. A bit of sensing to this. So although I've illustrated that the data in healthcare is very rich, but yet a challenge still faced in the healthcare industry is the data is still scarce despite it being rich and abundant. One problem is the 800 plus systems I mentioned earlier. The number of systems bring with it the complexity to bring them all together, to connect them all together. But another challenge that exists is also healthcare data, some of them being more sensitive than others and being more personal than others, comes with it the responsibility to make sure that it's used properly, the security and privacy that needs to be put in place. And that, in a way, also hinders data sharing to enable more innovation and collaboration with, let's say, the research institution to try to bring new ideas, new solutions that can be deployed. So the thinking behind this is, what if we can create data that can be shared to allow such innovation without compromising the real data that, that we have to take better care of? How can we do this using the same algorithm that we've already used for prediction and tweak it to do data synthesis? So at the bottom left, there's some mention of the kind of algorithm that's being considered, maybe to evoke a bit more of familiarity outside healthcare. If you've heard about the deepfake videos where there's possibility of using AI to create videos which are not real, that is one of the exposure of the generative adversarial network, the GAN, to the public. So that's a more nefarious use of AI for synthetic data. But what we have in mind here is actually more positive use. We want to generate synthetic data that look like a real data, the structure is like a real data, but does not contain information about a real individual, it needs to have a close enough statistical fidelity. It still needs to represent the population, the persons well enough, such that it can be used for various analytics use cases. Let's say for researchers to try to create new machine learning model. The synthetic data need to be effective enough, efficient enough for that use, and still preserve privacy. So this is an exciting new area, still a lot of possible application that we want to use. We envision that when this is available, it may be easier to share the data, let's say through hackathons, as in for wider use. And we can even use this data to create new training data for let's say trainee doctors. Let's say there's not enough X-ray images that can be used for from a real X-ray image to practice identifying certain condition. What about if we can create more test data that can be used for human to practice this? So this is a promising area that is still being explored, and hopefully also can dispel that not every technology that produces deepfake is just for bad, but we can try to find something for good for public health. Okay, so I've spoken for quite some time here on the 6 examples that I want to cite in terms of use of AI in public health. I'd like to take a break here and maybe hear back from the audience here. I see that there's a few questions that are coming in chat. Thank you for that. I'll have a look at it. But in the meantime, do log back into menti.com. You can use the QR code on screen or the code on the top. And I'd like to get some feedback on a few more questions. So I'll go in 5 seconds. Okay, here we go. So I've shared a bit at length on a few uses of AI, but for you yourself as audience, in your own life, if you get to use AI for healthcare, what would you want to use it for? So I think this is a bit more open-ended. Maybe there are different applications, but different level of comfort for people who want to use it. What are the kind of applications that you are comfortable using it? I see some examples like prevention. Some people may be comfortable with using it as, I don't know, recommendation. Is it something that you will be happy to use to recommend how to change some of your lifestyle? Or what about if it's used by the people who are supporting you? Would you be comfortable if, let's say, a nurse is assisting you with input from an AI model who recommend or identify certain condition? Or what are the kind of things that are maybe not so pervasive, but you're more comfortable with, or you're comfortable more with use to, I don't know, guide your, prompt you for dietary habit, but not really something which is more related to medicine? Okay, I see a good mix of input here. Prediction seems to be something that comes nearly 50% of the input here, which is good. Sometimes prediction is something that people are not so comfortable with. It's looking in the future, like looking into crystal ball. Some people just are more familiar with the here and now. I see first level diagnosis. Yes, that's one of the cases that is of interest, and we are happy to hear it. There are more and more people who are comfortable with use of that. Prevention, diabetes seems to come up a lot. So diabetes is a big area. If anybody wants to chip in more specifically what in diabetes that they are comfortable using AI for, I'll be happy to see more input here. I take it that the gentleman or the lady who say yes for sure actually will take AI for everything in their life. One of the champion of AI, yeah. Okay, I think the responses are slowing down, so maybe I'll move on to my last question before I continue. So on a scale of 1 to 5, how comfortable are you if we have more AI making medical decisions for you? This is where I lead from the earlier question. I see that the answer comes from both sides of the spectrum. And I'm quite pleased actually to see that the very comfortable and slightly comfortable is quite big in number while the answers are coming in, I'm expecting that it's actually quite fair to have a number of the audience member being not comfortable or not so comfortable, more so from the profile earlier where actually the audience here, not everybody have much exposure to AI or working in the AI field. So then I would expect that it's reasonable that there's some discomfort or distrust, but yeah, slightly comfortable being by far the highest number of polling responses. That's quite positive actually for people like myself to from the AI field to see, and this is a motivation to see that we are on the right track, that the condition may be right for us to push more and more in terms of delivering AI for adoption rather than just in incubation or research stage. Okay, maybe last call for another 10 seconds. Okay, I think the chart doesn't change anymore. So thank you very much again for the feedback. I'd like to wrap up the session with a few more items in terms of tips on how in our journey, experience from IHiS, etc., what are the things that we see will help in terms of increasing adoption of AI in healthcare. AI implementation needs to fit real world in the sense that, maybe I'll explain it from the first part first. A lot of AI scientists, data science people, all are pursuing improvement relentlessly. We want the model which is to be very good, very perfect, predict as accurately as possible, etc. However, that may not be necessarily lead to an adoption. I think the famous example is from the early days of data science competition, where people submitted models for a Netflix competition, how to predict a match of videos that will be liked most by particular people. The best model doesn't get deployed despite Netflix investing a lot of their money in that, because the cost to run the model is in fact even higher. So this is where real-life applicability comes into play. Technology on its own is not the whole thing. The most accurate model is not useful unless it gets to a point where it's worth it to be deployed. That's where it's necessary to establish a reasonable return on investment. What's the cost associated to actually develop and deploy it, and what's the benefit that we can get from the insight from the prediction. This ties to the practice of having a minimum viable product. One does not necessarily build a perfect product. It needs to be something that meets the customer satisfaction, customer requirement, and the effort to develop it needs to be catered accordingly, and feedback can be gathered for future development instead to see how to make the model more suitable for deployment. So in terms of setting the expectation for the people working on the AI model is one thing. We need to know that we don't always need to build the best in terms of prediction, but in terms of use. Similarly, this kind of perception is what we need to build mutually with the users. So sometimes in the movies, you see all those fantastical way how AI can be used, and the expectation may have been set differently. So this is something that we find is useful when we collaborate with the users themselves in the development cycle, rather than just developing in silo. It's both part of where we get to bring reality to us in terms of how well a model should need to be, and also to the users in terms of what are the limitations of data and what AI can do at this point in time. We can establish with the user a validation exercise to show how the model is good enough to improve their current operation, current need. We can create a predicted output for them to dry run in pilots, and they inspect and benefit, and then from there iterate and improve incrementally, and set the expectation that it will be a journey rather than one solution which solves everything magically. And along the way, we'll find out cases which are not perfect. No model is going to be perfect. Those who are in AI will know that this is a probabilistic field, and we will use those as opportunity to deep dive for cases which cannot be matched. Why? And then continue to develop from there as we work towards better and better improvement. So the involvement of the users actually also is needed to make the AI more human. than artificial, in the sense that we honor the knowledge of human and the use of this for human. Doctors, nurses, etc. They bring domain expertise that they can see from their work, their ground interaction. We may have a mountain of data, but we will not have data for everything, and especially those intangible things. So synthesizing and getting their input is definitely very useful in terms of creating a model which is more believable, more contextualized, which is actually pretty important in terms of adoption of AI. We will want to deliver AI output to be understandable and acceptable. There's a branch of AI that you may hear more and more nowadays on explainable AI. From a scientist perspective, it may be to satisfy curiosity. We want it to be explainable so that we can see when something doesn't make sense. Oh, what doesn't make sense? Can we fix them? But actually, from an adoption perspective, the other use is to make it credible, as in for somebody who wants to adopt AI, I will want to know if something works, why does it work? If something doesn't work, why doesn't it work? And if that can be explained, it makes it easier to understand and accept, and in a way, it gives a more human face to AI rather than just robot. The lesson about taking the user's input and perspective comes particularly relevant in one of our projects, in our earlier hospital-to-home project, for example, where we need to do a balancing to make sure that the AI actually works for the user and not the user work for AI. What happens is this: the aim is, of course, we want to predict something accurately. We want to predict accurately who can be cared for at home and doesn't need to come back to hospital. But in AI, there's a trade-off where if you want to be accurate, you want to be very precise, then you may need to sacrifice the breadth. At the same time, if you want to capture everybody and not miss out everybody, then you reduce the precision. And this trade-off needs balancing, because what happens is that when it's not tweaked correctly, we may churn out too many information. In this context, if there are too many people who are recommended for enrollment into this program, because we want to make sure that it's safe, we didn't miss out anybody, it may simply create more workload for the clinicians on the ground, which is the opposite of what the program wants. So that's where the Goldilocks principle comes in, just right. We work together with the user to identify what's the acceptable threshold that is acceptable from a clinical perspective, but from a workload perspective to the administrator is also manageable. And to wrap up, my last point is that humans should control AI and not the other way around. I think you will have noticed the central theme in my earlier few slides, all human, human, human. AI should be brought into business to integrate slowly, incrementally. So it should be starting with a business as usual, but maybe with a twist, a little bit of a change to the process workflow, which is why it's very important for every AI model, be it in healthcare or outside, that it be designed with a workflow in mind, and then everything to be tweaked accordingly. And the reality that everybody needs to understand is that AI's focus is actually to support human, not decide for human. AI should be used as a decision support, not a directive instruction to change, especially in areas in healthcare where the impact is more significant, where there are people's lives involved. This is where we need to recognize that however advanced AI is, a human, a clinician, a nurse, they are the one who can deliver the final service, and we are supporting them. So active involvement with the user via a lot of pilot will be able to make sure that any potential issue that may affect this use with actual human be uncovered. We can manage them accordingly. With that, I've come to the end of my presentation. Apologies that I ran a little bit over time, but I hope that the message has been useful.